Bismillahirrahmanirrahim. Assalamu alaikum, fourth year. Today we will start the remaining part of the topic, traumatic brain injury, which we had started a week before. Now the management of the traumatic brain injury, and we will begin with the medical management of the TBI. Early medical management involves and the overall goals of early medical management are: number 1 is medical stability, number 2 clearing of post-traumatic amnesia, number 3 is reduction of behavioral and physical dependence. The management immediately after trauma involves primarily life support measures. These are the level of consciousness, transfer to an acute hospital setting, investigations such as skull X-ray, CT scan, and MRI. So in some cases, intracranial monitoring will be necessary to ensure further damage or further worsening of patient conditioning that should not occur. Certain patients will require neurosurgical intervention, and if the patient does not require a high level of medical input, a less acute setting with intensive therapy services may also be appropriate. Now, on the later stage of medical management of the patient, a patient-centered rehabilitative approach is most effective way of management of TBI patient. Patients who are present with neuromuscular, psychological, and cognitive problems, and circulatory and even cardiorespiratory problems. So the early medical management and the later medical management, and the main purpose is to prevent the primary problems and even prevent the development of secondary complications. Now the physical therapy management of the TBI, and before the development of outcomes and development of plan of care, there are some elements of examination that should be examined before the development of the plan of care. And these elements of examinations are: number 1, aerobic capacity and endurance of the patient. Number 2 is arousal and attention and cognition. And there are different scales that should be used for assessment of the cognition and attention of the patient. And these scales includes now the different tests that can be used to measure the attention and cognition of the patient. These are cognitive coma recovery scale, and number 2 is Rancho Loss Amicus levels of cognitive functioning, and number 3 is Galveston orientation and amnesia test. The assessment, the examination includes behavioral status and the integrity of cranial nerves, and gait, locomotion, and balance assessment examination. And for assessment of balance, the scale that's most commonly used is Berg balance scale, that is used to measure, to assess the balance of the patient. Other points that must be factored in during examination of the patient after traumatic brain injury. These are joint integrity and mobility, and motor function, motor control and motor learning, muscle performance including strength, power, and endurance, and pain, posture, range of motion, and reflex integrity. Boys and girls, we just have discussed the different points of examination before the development of plan of care. Now our next point is plan of care, and that includes goals, TBI/outcomes. So any person with moderate to severe TBI present with a wide variety and degree of physical, cognitive and behavioral limitations. As the patient progresses in these areas, anticipated goals and expected outcomes will move from basic mobility and self-care towards skills that facilitate community inclusion and social participation. So now here there are some examples that includes the following. These are the main goals before the development of plan of care. Number one is the main goal is to reduce the risk of development of secondary impairments. Number two is the performance of functional mobility and ADL skills is increased. And number three goal is to improve the ability to assume and resume self-care and home management roles. Now the different intervention or different strategies that can be used for patient after traumatic brain injury, and we will start with the motor learning strategy. And that motor learning or relearning strategies includes self-modeling and concept of self-generation that is more beneficial to relearn new functional tasks. So for motor learning strategies, the treatment session should be thoughtfully planned to maximize the patient's motor learning capabilities, and practice should be distributed with frequent rest intervals. Due to cognitive impairments, patient may experience mental as well as physical fatigue during the treatment sessions. In motor learning strategies, the concept of self-modeling and self-generation shall be used. And with self-modeling, the patient watches himself or herself engaging in skillful behavior on edited videotapes. And in case of self-generation concept, that includes self-generation, and self-generated are better learned and remembered as compared to information that is provided. So two main concepts are used in motor learning strategies. Number one is self-modeling, and number two is concept of self-generation. Now the next strategy is restorative interventions and neural plasticity. Current researches has demonstrated that the task-specific interventions with large amount of practice can induce beneficial neuroplastic changes in CNS and restore functions. And there are studies involving monkeys and rat models of brain injuries have demonstrated that the importance of intensive and task-oriented training on neuroplastic changes in the motor cortex and functional recovery. Now the next slide is locomotor training with body weight sport. Locomotor training with body weight sport and a treadmill involves suspending the client in a parachute-like overhead harness that allows for a percentage of body weight to be relieved. So that type of intervention involves progressively decreasing the amount of body weight support and increasing the treadmill speed, allows the physical therapist to gradually increase the difficulty of task and walking ability as the walking ability improves. Another most commonly used intervention that is constraint induced therapy. So, constraint-induced movement therapy involves promoting the use of more effective upper extremity for up to 90% of working hours and reducing the use of the least affected upper extremity. So here the main goal is to promote the movement of the affected extremity, and that involves intensive task oriented training is provided for the affected extremity for up to 6 hours per day over a 2 to 3 week period. The last slide is patient/family/caregiver education. Patient, family, caregiver education and training are important goals across each level of rehabilitation. The goals of this education and training will vary based on the cognitive and behavioral abilities of the patient.